The surgery for an ACL reconstruction starts off with a diagnostic arthroscopy. This means the entire knee is examined for pathology, either to confirm other injuries identified on MRI or to identify problems that may have been missed. The cartilage of the patella and the groove it sits in looks normal. We also inspect what are called the lateral and medial gutters of the knee. If any pieces of cartilage are knocked off, they tend to settle here. We then drop down into the central compartment of the knee and create a second portal to introduce additional instruments. There is a normal structure called the fat pad, which sits in the front of the knee deep to the patellar tendon. Some of this is removed to improve visualization during the procedure. Next, we continue the diagnostic arthroscopy, inspecting the medial meniscus. This is a C-shaped ring of collagen which functions as a shock absorber for the knee. It helps dissipate stress and protects the cartilage. The top surface and the undersurface are carefully inspected for tears, which could require either a repair or debridement. Fortunately, no tears are found here. We also check the attachment of the meniscus in the back of the knee by pulling on it with a probe to ensure it is sound. The lateral meniscus is similarly inspected and no abnormalities are noted. This individual has a high-grade partial tear, meaning some fibers of the ACL remained intact. However, behind the intact fibers is seen the inflamed, torn stump of his ACL. Not all partial injuries require surgery, but this individual had symptoms of instability, which was also confirmed on examination. The ACL remnants are thoroughly removed to make space for the ACL reconstruction. The attachment point on the femur has been thoroughly cleaned, and now we do the same on the tibia. Next, a guide is positioned at the femoral origin of the ACL. Through this, a guide pin is advanced through the bone. This is used to ensure the socket is created exactly where we want it. Over this pin, a cannulated reamer creates a 10 mm diameter socket that is approximately 30 mm deep. The bone reamings are cleared out with a shaver, and then the previously placed pin is used to pass a high-strength stitch, which will later be used to pull the ACL graft into the knee. A guide is used to place another pin, this time for the tibial tunnel, entering the knee precisely at the tibial attachment of the ACL. A socket is also created in the tibia with a cannulated reamer over the guide pin, and then the shaver cleans up the soft tissue around the socket to ensure the graft will not be impeded during passage. An arthroscopic grasper pulls the blue passing stitch that was previously passed through the femoral tunnel down through the tibial tunnel as well. The bone, patellar tendon bone ACL graft is pulled into the knee with a passing stitch and guided into the femoral socket. Once passed, the graft still needs to be secured. A tap is used first, followed by an interference screw to secure the graft in the femur. This process is repeated outside the joint on the tibial side to provide secure fixation on both ends of the ACL graft.